Hello and welcome everyone. In this presentation, I will be talking about the chapter of family medicine. This presentation will has many sections. This is derived from the Toronto Notes 2020. And the first thing, we will be going through 4 principles of family medicine. Then we will be talking about periodic health examination, and it has many items with ending with the specific diseases screening guidelines. And then we will be health promotion and counseling section. And after that, there is the common presenting problems for the family physicians. And the end of the chapter, there will be some short discussions about the palliative and end of life care, complementary and alternative medicine, and primary care models. And there will be reference containing antimicrobial medications. So the 4 principles of family medicine, according to the College of Family Physicians of Canada, that the family physician is a skilled clinician. And obviously he has to see patients, diagnose and manage their diseases. He has to recognize early diagnosis, and there is an element of emergency medicine in managing serious life-threatening illnesses. The second principle is that family medicine practice is a community-based practice. It means that it provides the healthcare information and provide resources for the community, and it responds and adapts to the changing needs of the circumstances of the community. The third principle is that the family physician is a resource to his patients to defined practice populations. So should there be any concern of the patients, they should get back to their family physicians, and he is the one who advocates for their health policy and promote their health. The last principle is that the patient-physician relationship is central, and the family physician does not just treat the patients or treat the disease and move on. He has to build a good and good and long-lasting relationship with his patients, and this relationship is central in his practice. So moving on to the periodic health examination, it means that there is a certain blood tests or certain recommendations derived from the Canadian Task Force on Preventive Health Care, which will be published on their sites. And the recent updates were in 2015. These recommendations are based on systematic analysis of scientific researches and evidences. So they sit and do systematic analysis and derive the most important recommendations and most appropriate recommendations for the periodic health examination. And this is recommended instead of annual, every year examination, physical examination. It's a comprehensive, it consists of more than just physical examination, as we will see. And its purpose is derived towards a primary prevention point and secondary prevention. The primary prevention, we are here concerned with the risk factors for the diseases, and we counsel the patient, we promote their healthy behavior, and we immunize them. We're giving a vaccination in order for them to get immunity. The secondary prevention is aimed towards detection of asymptomatic patients in order to early detection and to prevent progression. So the secondary prevention could be screening for example, PSA for prostate cancer, and screening with colonoscopy, for example, is considered as secondary prevention. There is another tertiary prevention. It's not mentioned in this chapter in the book, but it's targeted towards mitigating complications and disease progression after they occur. Example for that will be patient who has autism. They can benefit from psychosocial counseling and psychotherapy, and also the deaf or mute patients who can benefit from the speak and language therapist. That's also will be considered a tertiary prevention. Classification of recommendations. There is a classification according to the strength of recommendation, and there is a quality of evidence used in this recommendation. So after looking up into the evidences, we will classify their quality into high, level of confidence, and moderate, and low or very low, which means that the true effect derived from this evidence may substantially different from the estimated effect on the real patients. And the recommendation strength, after they look into the evidences, is built on either strong recommendations, which has confidence that the desirable effect outweigh undesirable effects. And there is a conditional, which desirable effects probably outweigh the probably undesirable effects. So here it's confidence that the desirable effects outweigh undesirable effects in the strong recommendations, while in the conditional, it's probably outweigh the undesirable effects. So it means that it's not as strong as it should be. And the conditional one implies that most people would want the recommended course of action, but that many would not. Different choices will be appropriate for different individuals. Patients require support in reaching management. It means that some recommendations which are conditional, it should be tailored towards specific type of populations who may benefit from that, because it doesn't have enough strength for it to be applied on all people. This table here, periodic health examination table 1, it's very comprehensive table. It's divided according to the general population periodic health examination or special population periodic health examination. And the steps during a clinical consultation is laid out here as discussion, which means the phase of history taking, physical, which means physical examination, tests, which means when we order the tests after we are done with the history and physical examination. And the last thing is the therapy. We can see, for example, discussion in general population. We can ask about dental hygiene, noise control, screening poverty, smoking, nicotine. And the letters mentioned here is that it means how much the evidence derived for this. Is it a moderate quality or high quality of evidence? And in special populations, it means pediatric. You will do some home visits for high-risk families, and so on. And in adults more than 65, we will follow up on the caregiver, concern of cognitive impairment, and multidisciplinary post-fall assessment. This table is high yield. Actually, there are some points might come into in your exam, and it will be showing, for example, what do you order for pediatric patients in their periodic health examination? You will routine order hemoglobin for high-risk infants, and you will do blood lead screening for high-risk infants. Not much mentioned about high-risk group here, but you could figure it out from the question STEM. The other thing is the therapy, and this is the most high yield of the table because it shows here immunization and which special group that requires certain immunization and which one you would offer to the general population and at what age. On the side of the page, you could see that there are folic acid supplementation in pregnancy. So it's a special population. What is the recommendations regarding folic acid? In summary for this, the folic acid dose should be from 0.4 to 1 milligram at least 2 to 3 months before conception and before getting pregnant and throughout the pregnancy and 4 to 6 weeks postpartum, 4 to 6 weeks postpartum. This is in low-risk women. That means women who didn't give birth to patients who has neural tube defects or patients who doesn't take medications which contradict the folic acid action, such as anti-epileptics. High-risk people or high-risk women who has insulin-dependent diabetes or who has epilepsy or anti-epileptic uh, and who is BMI is more than 35 or has family history of neural tube defect. So these people or these patients should have taken 5 milligram folic acid 3 months before conception and 12 weeks post-conception. Very important piece of information. And from week 12 post-conception until postpartum period, so from 12 weeks post-conception until postpartum, she should get back to the normal dose, which is 0.4 to 1 milligram of folic acid. So she will take high dose, 5 milligram pre-conception, 3 months, and she will continue on that till 12 weeks after conception. And then after the week number 12, she will get back to the normal dose of folic acid. And women with additional lifestyle issues, which has poor compliance, they could benefit from high folic acid dose, which is 5 milligram. So the question might come with a patient who has poor compliance and no consistent birth control and taking possible teratogenic substance. You would recommend a high folic dose of 5 milligram and counsel about prevention of birth defects. That's pretty much most important information so far. And I would recommend going through this table as long as you get some of the important points in this table. And we will move to in the next section to the specific diseases screening guidelines. We'll try to make it as brief as possible and quick to be memorized. Thank you and see you in the next section.